Okay, so final session of the conference. I'm Oliver Cassell, I'm one of the plastic surgeons in Oxford, and I'd like to introduce you to, I've got Andrew Birnie, who's a dermatologist in Canterbury, and together we're going to take you through surgery from top to toe. And I haven't actually met my nursing colleagues. Where are they? Ah, here they are. Good. And I when I was chatting to Imogen about this, I thought it was important to have some CNS input, because increasingly around the country, to varying different extents, a lot of the follow-up and the examination and the detection of melanoma is being left to specially trained nurses, part of this, or CNSs, part of the team. So I think it's important, as that may be what you're experiencing wherever you come from. So I'm delighted to say that this is about the only conference where I can justifiably say it's sunny and hot outside, so we're going to spend as long as we want in here, because there's no rush to get out there. Okay, so we'll start off then session with Andrew talking about early detection, and we'll move on from there.
Hello, thanks very much for having me. As Oliver said, it's a unique conference, it's a unique opportunity, and I was glad to come up last night, and it's interesting listening to Rollo's talk. There's quite a lot what he was saying which I'm going to echo today, so at least we're all singing from the same hymn sheet here. And it's a sort of conflict of interest, but it's also a bit of a plug as well. Many of you have come across the Altruist sunscreen, which I've been involved in producing, and obviously I've got to sort of declare a conflict of interest, because I'm going to tell you to protect yourselves from the sun. I suspect most of you do anyway, but equally, as I say, I need to tell you about that. It's sold on Amazon, and it's going really well, so any support you can by telling people about it is gratefully received as well. Thank you. So, despite the fact you guys have had melanoma, it's still probably better for you to get out there and live a healthy outdoor lifestyle, the cardiovascular benefits, the psychological benefits, and so on. So get out there and still live your life, but obviously protecting yourself whilst doing it. And as a consequence of that, and also as a consequence perhaps of this cohort of people having perhaps a little bit more sunshine than maybe the average person, you're going to potentially be at risk of other sorts of skin cancer as well. So rather than just dwelling on melanoma, I'm going to mention some of the other types of skin cancer, the more common non-melanoma skin cancers too, and what you should be looking out for there. So, when you're a medical student, you often sit down having fairly macabre discussions about, for example, right, you've got to have a type of cancer, which one are you going to choose? And almost everyone would choose a basal cell carcinoma, because it's, on the whole, not life-threatening, doesn't tend to spread, and this is the most sort of benign version of it. It's a superficial one, and often it just appears as a little non-healing patch. It might be a bit of eczema, you think, that's just not healing with a steroid cream, and that's when you might start thinking that it might be something else. And there's a variety of different options. You can use creams, they can be scraped off, you can have photodynamic therapy or surgery, but ultimately treatment for these is pretty straightforward. Nodular basal cell carcinomas are a little bit more noticeable. They tend to be raised, and they can be ulcerated like this one, with rolled edges, and the edges are often a little bit pearly, and the problem with these is that they ulcerate, they bleed, and they can be a real nuisance, and particularly when they're close to the eye like this, they can actually track round the back of the eye if they're untreated and cause an awful lot of morbidity. This, on the right, shows the healed up version of it after it's been removed and allowed to heal up by itself, in fact. So don't be afraid to seek help, because actually you don't necessarily end up with terrible cosmetic results afterwards. This is a more typical nodular basal cell carcinoma as well. This one's not ulcerated, and it's got, let's say again, almost a pearly-like appearance, and what's called telangiectasia. So these are little blood vessels that grow up on the side of it. This one's been removed as well, and a skin graft allowed it to heal up very nicely. So again, despite its location, if you can treat that early, you can see that taken out, you can have a nice result. The longer you leave it, the larger the hole will be, and the more likely you are to have sort of bad cosmetic result. So, as I said, they're typically pearly in appearance. They have often got this telangiectasia, these little blood vessels, and most often you would excise them. And you would either excise them with a standard margin, or you might do Mohs surgery, which some of you might hear, but that's another talk to tell you about that. Radiotherapy is another option as well, and you can get very good results, though typically that's reserved for older people because the long-term results of radiotherapy aren't quite so cosmetically great. We don't recommend the more topical treatments for nodular basal cell carcinomas. So the most difficult to treat are the morphic basal cell carcinomas, and that's because their margins are a little bit less obvious. This one's been removed by Mohs surgery and been repaired by a flap, and you can see that it's sort of come down and fixed it up. So what happens if you don't treat basal cell carcinomas correctly? Well, potentially, if they're incompletely excised, they can keep coming back. And this next picture shows you a lady who had a failed excision on a couple of occasions, and eventually we had to take it out fully. So they can be very destructive. This lady had, it would take a long time to make the diagnosis, is probably the nicest way of putting it. And this is not meant to be a criticism at all of the GPs. And again, that was a big discussion last night. And I've got an awful lot of sympathy for GPs, particularly with melanoma. And most GPs will probably see one melanoma in their entire career. So if you put it in perspective like that, it's not surprising that they don't always pick things up first time. So this one actually was very invasive and destructive as well. So you can see that they're not always these nice little friendly tumours that people will often describe. So it is worthwhile, if you've got something that's grown, a little lump, something that's not healing, do show your doctor. And that's her being stitched up afterwards. And here's a lady who said, oh, I'm old, I'll probably die soon, I won't bother with dealing with this small thing on my leg. And it gradually grew. This actually lasted 27 years till she eventually decided to present. So it didn't grow very quickly, but it's much more difficult to treat now that it's a massive ulcer on the lower leg. And the other thing I say to older people is that you're actually fit and well now, relatively speaking, and actually if you leave it longer until you actually deal with it, you're probably not going to be as well, and the treatment will be more difficult because it will be bigger, and you might not be as fit. So usually I do recommend treatment. Very briefly, solar keratoses. These are slightly different. These are scaly, sometimes itchy, almost cornflakey-like bits, often on the back of the hands, on the scalp, on the face. They're not skin cancer, but they're a marker of the fact that you've had quite a lot of sun exposure over a lifetime. They're relatively easily treated with creams if they're diffuse. They can be frozen off with cryotherapy if they're solitary. Photodynamic therapy is another option, and again, if they're little lumpy ones, you can scrape them off. There is a very small percentage of them that might move on to a squamous cell carcinoma, which I'll show you now. But it's probably more to do with the fact that the people who develop squamous cell carcinomas and the people who have actinic keratosis have both had quite a lot of sun exposure in their lifetime. So this is actually a place, this is called Spandokop. This is a place in the Karoo of South Africa where my wife comes from. And always reminds me a little bit of a keratoeic anthoma, which is a type sort of similar to a squamous cell carcinoma, so hence the appearance. And yeah, here's a fairly typical squamous cell carcinoma on the lip of this chap. And again, you know, there's no reason to fear these things on the whole if you get them seen to quickly, because they do tend to grow much quicker than basal cell carcinomas. They can be cut out and stitched back together again. This one, again, didn't leave it too long. It was several months, but yeah, you can see it's grown quite quickly, and it creates a fairly sizable defect. But again, most things can be fixed up reasonably well, and you can end up with quite a nice result cosmetically having had it cut out. So the key thing is get it done quickly, get seen quickly, and squamous cell carcinomas are seen on the 2-week wait. Another one. This one is sort of very much keratoeic anthoma-like. They grow very quickly. They've got that keratin, that hard plug in the top, almost looking a bit like a volcano. And again here, this is a slightly more sort of ulcerated surface. Again, this was another type of squamous cell carcinoma too. So again, squamous cell carcinomas in the main are again, once excised, treated, done, no problem. But they tend to need a little bit more follow-up if they're at higher risk, and they can cause problems. So again, you do want to make sure they're treated properly. And this is a chap that I met when I spent a year in South Africa, and he'd had photodynamic therapy to some patches on his temple a number of years ago. And it doesn't look all that much on the side of his head, with just a little bit of ulceration there. But it was fairly obvious something bad was going on, because that's what he looked like from the front. And what had happened is that the photodynamic therapy had treated the surface of the skin, and the squamous cell carcinoma was still active underneath, and it knocked out the nerves. So this subsequently got removed, and actually he ended up with a really large hole on the side of his head to get things clear. Another example of a squamous cell carcinoma that's been sort of basically run away and got too far, and this can cause quite a lot of problems as well. So they tend to be more rapidly growing. The higher risk types are the ones that are big to start with. They're around the mouth and the ears, and the differentiation, how they look under the microscope, can increase the risk as well. People who are immunosuppressed, so on medication, perhaps for an organ transplant or to suppress another inflammatory condition, are higher risk too. But as I say, excision tends to be the main way forward here. Another picture. This is back home in Kent. This is Botany Bay. So moving on now. Less cheery picture. I think most of you have come across this sort of graph before, but this pretty much is the crux of the melanoma bit of this talk. If you're diagnosed early, your chance of survival is much better. And the 1A, these are the sort of stage 1, stage 2, so these are the ones which haven't spread at this stage. But you can see that the difference in the Breslow thickness makes such a difference. So, as Rollo said yesterday, this is what everyone's typically told to look out for: asymmetry, border, colour, diameter, evolution, the ABC. But I think that is unfair to expect you guys to really sit there, look at a lesion and say, is that the case? With ones like this, it's easy. This is clearly abnormal. This is clearly abnormal. But this is not the ones which are difficult to work out. This is not, ooh, is this a melanoma, or is it not? It's the ones which are actually, don't look that much different from everything else around them. So I advocate people looking out for new or changing lesions, and also what you might call the ugly duckling. So one that stands out as being different from the others. For example, this young lady doesn't look that different from the others. It's slightly bigger, but she noticed a change. This is something that she hadn't noticed before, and it appeared. So she reported it, and it turned out to be a relatively thin melanoma, 0.7. So hopefully cured. This chap, again, this one's very much an ugly duckling. But again, it was a new lesion that he actually hadn't been aware of. He'd been sitting at a beach bar in Florida, and some attractive young ladies came up to him and he thought, hey, my luck's in. And I went, you need to go and see your doctor about that thing on your back. But not everything new and ugly is a melanoma. Seborrhoeic keratoses are far more common. So just because you've got something that's not very nice on your body doesn't necessarily mean it's a cancer. And these are usually fairly easy to identify as not being cancers. But then I don't expect you to have to make that decision. This also is a seborrhoeic keratosis. Again, looks a little bit different, but again, is benign. This one looks quite scary when you first look at it, but when you look more closely, particularly with a dermatoscope, again, which I don't expect you guys to have, it is actually just a vascular lesion, so it's a hemangioma. So again, it's benign. So not everything new and changing is nasty. This, again, was a story of change. If you glanced at her back, you probably wouldn't notice it. But if you look closer, she noticed that it changed. You look even closer at it, you can see actually it's clearly very abnormal. And again, another thing you might want to look out for are changes on the face. I mean, lots of people have what they regard as liver spots, sunspots, little brown marks on their head, the cheeks, the back of their hands. And more often than not, it's just a reflection of sun damage, sun exposure, and it's nothing particularly concerning. But when they become much darker, when they become irregular, that potentially means that there's something to worry about. And these were biopsied and shown to be a lentigo maligna, which is a melanoma in situ. So this would need to be excised to reduce the risk, or hopefully stop it turning into a melanoma. Again, a melanoma in situ is something which, if you can treat and get rid of it completely, means that pretty much you can prevent a melanoma from occurring. So really, a melanoma excision is, well, I've actually changed this. I had this slide on previous presentations. I used to say melanoma excision is the only chance of cure, whereas actually now some of the treatments coming through, there is a possibility that actually there may be other cures, but certainly without any doubt, it's the one you want to go for, is excision. So early detection is the key, and of course prevention. That's got to be the key message, prevention. But if you can't prevent it, then try and pick it up early. So what about people who've already had a melanoma? This is a melanoma that was excised from the calf. But about 9 months later, these little red spots appeared alongside the scars. So these are in-transit metastases. These are the sort of things that you guys need to be looking out for. And the interesting thing here is that they don't always look black. You know, the original melanoma was a black thing, quite ugly looking. These are little red dots, but actually they were melanoma. So new things that appear are things that you want to be keeping an eye out for. Likewise, on the ankle here, these ones are not black. The original melanoma was, but despite that, these are deposits of melanoma. And again, whilst the treatment for these is just excision, it's obviously easier to excise them when they're smaller and there's less of them, and you're going to move automatically onto another stage if you've discovered these, and you'll need to have scanning and so on. So you want to get this detected as early as possible. So changes around the scar, changes often on the same limb or near to the area, are perhaps a sign that you've got some sort of recurrence of the melanoma. So with regards to melanoma, you really want to be thinking about reporting new or changing lesions, and that's really got to be the sort of the take-home message. And I don't think you need to worry too much about that A, B, C, D, E. Look out for the ugly duckling, something that stands out, because often you'll say, I don't remember that being there, but that really looks different. Or that stands out now. And actually look at your family and friends as well. That's when you might be thinking, that just doesn't look right. And say to them, you should go and get that looked at. And, of course, prevention is better than cure. And as we all know, the only modifiable risk factor at the moment for melanoma is sun protection. And so, your slip, slop, slap has worked in Australia. The incidence of melanoma is not increasing anymore. It's still high, but it's not increasing. It would be great if we can get to that stage here. So, concluding from the melanoma perspective, sun exposure is the only modifiable risk factor. Early detection has got to be the key to the cure, and self-examination is important, which we'll come on to a little bit later this morning. And you want to be reporting new or changing lesions rather than worrying about the A, B, C, D. So to conclude, all types of skin cancer, there's many different types. I don't think you should be expected to be able to make the diagnosis yourself. You need to identify something that's new, changing, non-healing. So if something's been on a lesion that's there, it's been there for 2 or 3 weeks, it's not healing, you think, doesn't look right. Get yourself seen by the doctor. And almost everything can be cured by early excision. Of course, there's no 100%, there's no guarantees in life, but certainly that gives you your best chance. So I'm happy to take any questions at this stage, or are we going to do questions all at the end? Okay. Thank you.